At the outset, I'd like to thank Mark Speakman and BAUS for this very kind invitation, looking after me so well. It's lovely to be back in Britain after many years. And to thank Anil for inviting me for this talk in IBUS. Can we get on to the next one? How do I? Yes. I bring you greetings from India in general, and Mumbai in particular, a very charming city where the old blends with the new, and where the placid blends with the chaotic. And in 2 years from now, we are going to have our national conference in Mumbai. It will be the 50th year, and you're all welcome to come to Mumbai. Now, before I go on to telling you about how things have changed in PCNL over the last 30 years, I'd like to sort of put something in the sky as to what is an ideal, what I think is an ideal PCNL. It's a perfect puncture, and that's another topic entirely, and books could be written and lectures could be taken on how to get about most of our trainees to do perfect punctures. But that's not the topic today. Minimal dilatation, so that if you've done minimal dilatation, you have less bleeding. Minimal number of tracks, again, the more the number of tracks, the more the morbidity, more the bleeding. No, that's it, and no tube. If you had a small track, you can leave the patient without tubes, so no tube outside no nephrostomy tube, and no DJ as well, beyond 24 hours. And therefore, patient can go home the next morning. That's the pie in the sky. Can we achieve this? Yes, in about 75 to 80% of patients, you can achieve this. And in about 25% where it's necessary to have a second look nephroscopy, then you intentionally cannot achieve this. Now let's talk about the story of PERCS. I'd like to describe the story of PERCS in two segments, the first 10 years and the next 20 years. Let's talk about the first 10 years, and these are the pioneers. I had the good fortune of working with John Wickham and with Arthur Smith when they started PCNLs. And the Chapman Center is, of course, Alkan. Our first 10 years, and this is our experience with the first 10 years, where we did about 1,350 cases. Many of them were large stones, more than 3 centimeters, 878. They were all dilated to 30 French. They all had nephrostomy tubes. They stayed about an average of about 4 days. And the grade 3 complications were about 4%, generally either sepsis or bleeding, occasionally extravasation. And we thought we had a good thing going, and this was, we presented it in '92 at the World Congress. And I would like to draw your attention to the fact that clearances were pretty good, ranging between 70 or 71% for full stacks to 98% for single-site stones. And it looked like this is a very good technique. There was no further need for improvement. It was a fully validated technique. But then, so we said at the end of 10 years, excellent technique for larger stones, particularly staghorn stones, where the other alternative was to do massive open surgery, acceptable morbidity, good clearance, even in staghorn calculi. Now, if you look at any technique beyond the stage of innovation, you have validation. Then, after you've validated the technique, you really start scratching your head and try to improve things, make things better. And then you expand the indications to apply to a larger spectrum of cases. Now that needs revalidation, and then you know what's the real level of the champagne. So what's happened in the last 20 years? How have we improved? Have we improved at all? I'll just take you through these points which I would like to discuss, and then you make your decision whether we have actually gone a stage better or not. Image guidance, slender nephroscopes, smaller tracks, better fragmentation energies, tubeless PCNL, suction at PCNL, something I'd like to spend some more time on, supine PCNL, and finally combined with our IRS. These are the areas I think that we've addressed. The first is perhaps the least important, image guidance, and we started with doing punctures with fluoroscopy or ultrasound and the dilatation under X-ray control. And today we have very much the same techniques. All the attempts are using laser or computerized tomography or use stereotactic surgery and punctures are not ready for prime time, and they've not proven helpful at all. So next we go on to this, making the scopes more slender. The first report about using a slender scope was Jackman's report of using a ureteroscope through a smaller sheath for pediatric patients. Now, I'm quite sure that there must have been other people doing it. This is myself, in about 4 years before Jackman's report, using a ureteroscope through a PCNL track for a smaller stone. And the Chinese were reporting from 93 using ureteroscopes through peel-away catheters, and long before we were even aware that they were doing that. But the credit of making purpose-built, smaller scopes that would do the job must go to Udo Nagele and Sven Lamer, working with Storz and Wolf respectively. They both made roughly the same kind of system, a 12 or 13 French nephroscope, which was to be passed through purpose-built sheets, not exceeding 21, but generally about 14 French, 16 French in size. The question obviously arose when you've got such a small nephroscope, how do you manage to retrieve fragments? And whereas the Wolf scope had a small forceps for picking up smaller fragments, not very effective, Udo Nagele maintained that he used the vacuum cleaner effect, which is something we've all experienced. When you withdraw a scope, the stone tends to follow you into the sheath, but then it goes back inside. So if you withdraw it with a gentle, continuous force, you can manage to retrieve the stone. Not always effective, particularly not effective if you're a large collecting system. Then comes the stage of validation. We have numerous articles. This was from Mahesh Desai's people from Nadiad, where they showed that smaller sheets gave less bleeding, quite expected. And this is a lovely paper which shows, if you see the left-hand side, that as the sheets reduce in size from 30 French to 16 French, the bleeding and transfusion rate goes down dramatically. Now that was an obvious conclusion. I was looking for some papers that would show the levels of clearance of calculi as scopes became smaller. And these two papers maintain that there is equivalent stone clearance rates. It's my impression, although I can't have figures to show it, that actually the clearance rate improves. And there's only one paper that does address, this is from Germany, and he's compared two equally matched cohorts, only the one on the right, the stones are a little larger, but if you see that the stone clearance, though it's statistically not significant, is better with the MPCNL. Why is it so? Why can you get better clearance? We can understand you get less bleeding and less morbidity, but why do you get better clearance with smaller scopes? And what I would propose is because of maneuverability. You usually, for a larger stone, you go from the upper pole, or for a stone which is in both upper and lower cases, I would go from the middle pole. In either of these cases, you can manipulate your scope into almost all calyces of the kidney if the scope is slender. As if this was not enough, my dear colleague Janak Desai, with whom I had a pleasure of working with some time ago, devised a scope which was even smaller. This was a small scope going through an 11 French sheath. Obviously, the only fragmenting technique you could use was laser. There was no ability to retrieve fragments other than using flow. So he used the Venturi effect, which in effect is actually push. You push fluid and ask the stones to come out, which is something the Chinese have been doing also, because they use pressure irrigation and pressure from the ureteric catheter to have a high pressure system inside the kidney that causes fragments to be pushed out. To go still further, Bader had devised an all-seeing needle to see how his punctures were. And this needle was used by Mahesh very ingeniously, Mahesh Desai, to do the entire PCNL, to do the entire procedure. So you have the micro PCNL, which is exceedingly small. It's only a 5 French needle through which the entire PCNL is done. I wonder it's lovely to see that it can be done, but if one has to then see validation as to whether decreasing this nephroscope to this size adds any particular advantage in any particular scenario. It's a good technique, looking for an indication. Slender scopes to smaller tracks, therefore, have meant less bleeding, better or equal clearance, no tubes in most cases. Now let's go on to beyond this. If you were to use slender scopes, then obviously you were looking for techniques of fragmentation that was superior to those that you've been using so far. And let's see what we've done there. The initial ultrasound fragmentation was replaced by pneumatic because it was more effective. Pneumatic was further made more effective by incorporating ultrasound, and that was along with it, so the dual technique, which we call the lithoclast master, and it had suction, so it was great to control the fragments. The Chibber one had the same effect, very effective fragmentation and suction. But as you brought the nephroscope down to 12 or smaller, obviously neither the lithovac master nor the Chibber one could be used. So you had to have something which was effective and could be passed through very small nephroscopes. And the obvious answer would remain laser. Now laser at 30 watts was capable of doing just this much and no more. Now we have a 120 watt laser, and yet I think this is still to be, as I look at some of the papers, I won't talk about this, I talk about this. This particular paper that comes out of China looked at the low power settings and high power setting. They compared a 30 watt laser with a 70 watt laser. The settings are most important. On one hand, you had a 2 joule setting with a frequency of, I can't read it from here, 15 hertz, I think, and a 3.5 joule setting with a higher hertz of about 20 hertz. Obviously, the second setting was using it as a duster vaporizer sort of fashion, whereas the previous, in lower power, you use it as a drilling pulverizing setting. We need work on this, to be sure whether high power laser and high settings are safe in the kidney, and in addition to just fragmentation time, how does it help in the elimination of fragments? What is the residual rate after both these settings? And I don't think there's any paper as yet on this. This brings me on to the next topic, and that is suction. I would call this fragment management. In a large stone, if you are not careful about managing the fragments go all over the place, and it makes the procedure not so controlled. So in order to manage the fragments, you have to have suction. So you keep the fragments very much near the tip of your fragmenting device. As I was telling you earlier, as the scopes became smaller, managing suction through the nephroscope became an impossibility. Now, it was an obvious conclusion to this that the suction should be shifted to the sheath, but it required someone to do that. And so I'm sorry, I've said all this already. And the person who did that was a friend of mine called Shaw Wan, who lives in America but works with the Guangzhou University in China. And he devised this extremely simple 3 sheets. That's 12, 14, and 16 French from top to bottom. And you see hanging below that a kind of a side limb. The side limb is of the size of the internal diameter of each sheet. So stones of that size will come into the sheet and they go down the side limb into the collection device. You have a rubber bung on the left-hand side of the sheet that makes it a watertight fit. So the suction is transmitted to the tip of the sheath. Now I'll show you this at work. So here's the sheet inside place with the suction attached to the side limb, and you're inside the scope, inside the kidney, doing the fragmentation. As you find that your fragments are now small enough to come out through the sheet, what you do is withdraw your telescope, the fragments follow you into the sheet, and you put your thumb, you can see the left on, you see below you, I put my thumb on the small slit, very much like you would do in a Yankawa suction on open surgery, where you have a small little hole on the top of the suction, and you put your finger there, and it enhances the suction. So you put your finger there, it enhances the suction, the fragment gets sucked into the sheet, and as you withdraw your scope, the fragment goes down the hatch, down that side limb. You never need to use a withdrawal device. There you see, this is lithoclast at work. Although I think that as your scope becomes smaller, I would like to use laser more frequently than the lithoclast. That's the laser being worked. Because of the suction, you'll see the system collapsing. So you use the suction cleverly to prevent excessive collapse of the system, but you keep the fragments in front of your sheet. And as the stones have been fragmented, they follow you in the sheet, there, down the hatch. They follow you into the sheet, and there they go down the hatch. So you keep on doing this repeatedly, and you do not need to either take your scope outside the sheet, nor use a retrieval device of any sort. At the end of the procedure, this is with a 16 French sheet, and I think you can do almost anything, including larger stones, with a 16 French sheet. So now let's go on to the next thing was this concept of supine PCA, an excellent concept, the Gattaca modified supine Valdivia approach. And we all know that this is an excellent approach, has two great advantages. One, in addition to, of course, the obvious advantage of anesthetic preference, one is that it affords excellent drainage of fragments, because the fragments are more dependent. It's, as I say, it's preferable to go in from the floor than it is to go in from the roof. You don't have to be Santa Claus and come into the kidney from the chimney. And therefore it's excellent as far as retrieval of fragments are concerned. And the second advantage is that you can simultaneously do flexible ureteroscopy with. These are the great advantages the system has, but it has two great disadvantages. In my hands, it is almost impossible to do an upper pole puncture using this technique. I've heard that some people do it, but I would love to learn from them how they do upper pole punctures in the supine system. The second thing is the maneuverability in the supine position is not half as good as the maneuverability in the prone position. So that brings me to the next thing. I read this paper once on combined PCNL with ureteroscopy from Chinese source, and I tried to apply it to my large staghorn calculus, doing it simultaneously, and I had the same problems that I told you about. One, I could not do upper pole punctures. Two, maneuverability was quite poor. And third, I found the ureteroscope in the way when I'm doing a large staghorn. So I thought it was pointless to use it at the first step. But if you see this particular case, you have a large staghorn calculus, and at the end of the procedure, due to bleeding, I had to abandon the case, and there you have multiple, all the stones have been beautifully fragmented. The fragments are relatively small, but they are in the ureter, they are in almost every single calyx, and I had recently read that paper, so I chose to do a supine PCNL, and since then I've done 15 of them, and I find this excellent. It's an excellent technique for a second look nephrostomy. I would not do a second look nephrostomy in anything but a supine position, because it affords excellent drainage, because I can simultaneously use my flex URS and therefore afford maximal clearance in the second sitting. So, in conclusion, in the last 20 years, what have we done? We've made slender scopes of the size not larger than 12 to pass through sheets not larger than 16 with suction, and I feel that this should now be called conventional PCNL. There is no need to go higher than this. This is conventional PCNL. Because no bleeding, there are no tubes, shorter stay, usually 1 to 2 days, unless you're looking at second look nephroscopy, in which case extended to 4 or 5 days. Better clearance, A second look nephroscopy should preferably done in the supine position and be combined with flexible ureteroscopy. And the last message I would say is the enhanced efficacy of high power laser is something we need to do work on before we use it. But as I say, as you make the scope smaller, to my mind, the only thing that is likely to be there for use is high power laser. I extend an invitation to the Urological Society of India's conference in India, January 7th onwards. It is in Hyderabad, which is a lovely city. It's a city of palaces. The erstwhile Nizam of Hyderabad is reputed to be one of the richest men in the world. It's got lovely palaces all around. It's a beautiful city. I urge you to come and attend this conference or send in your papers. We want papers from foreign sources. Thank you very much for your patience.